Neonatal peripherally inserted central catheter placement is a catheterization technique in which the catheter is inserted through a peripheral vein, with its tip positioned in the superior or inferior vena cava, as a medium and long-term intravenous access device. Neonatal catheter has the advantages of long indwelling time, minimal operative trauma, and few complications. It is widely used for medium and long-term intravenous infusion. Neonates requiring infusion for greater than 7 days. Neonates requiring administration of hyperosmolar, non-physiological pH, irritant, or toxic medications. Premature infants, low birth weight infants, especially the treatment of very low or extremely low birth weight infants. Infants with the poor vascular conditions. Newborns with difficult peripheral venous access. Infants requiring total parenteral nutrition infusion. To address issues related to long-term infusion and nutritional delivery. This video included indications and contraindications. Pre-catheterization preparation. Catheterization process and identification of the catheter tip. Indications. Contraindications. Guardian signed a consent form. Evaluate the neonate's biochemical test indicators. Vital signs. Assessment of vascular conditions. Skin integrity. Prepare a septic operation. For the insertion site of neonatal catheter, the basilic vein of the upper arm is the first choice, because basilic vein is straight, large relatively, and has fewer venous valves. The median vein and cephalic vein are the second choices. When selecting a vein in the upper arm, please note that there are numerous branches at the junction where the axillary vein joins the subclavian vein, which the displacement may occur. In addition, neonates can choose the superficial temporal vein and posterior auricular vein on the head. Many peers choose the great saphenous vein and femoral vein of the lower limb. The vessels are large, making catheterization and fixation easy, but it should still be noted that they have many venous valves. But once common iliac vein thrombosis may pose a higher risk due to limited collateral circulation. The inability to compensate for blocked venous return can lead to severe limb complications. Preparation of supplies. Disinfectant. Normal saline, tape measure, scissors, forceps, cutter, puncture needle, infusion connector, syringe, gauze, sterile whole towel, transparent dressing, adhesive tape. Place the punctured limb at a 90-degree angle to the trunk. Measure from the puncture site to the sternoclavicular joint, and add 1 cm or 0.5 centimeters. Measured at the midpoint between the acromion and the olecranon. It's very important to record the arm circumference. During catheterization, closely monitor vital signs. Wrap the infant. Provide comfort. Administer sedation as prescribed by the physician when necessary. Catheterization. A nurse opens the kit. Checks the catheter length. And trims the catheter according to the measurement. Flush catheter. Fully immersed in normal saline. Meanwhile, another nurse cleans and disinfects the infant's skin. Clockwisely. Counterclockwisely. Drape the area to establish a maximal sterile barrier. Verify patency of the puncture needle before use. Puncture. After successful puncture with blood return, withdraw the needle. Deliver the catheter slowly. Once the catheter passes through the sheath, turn the infant's head toward the puncture side, with the chin resting on the shoulder, to reduce the risk of catheter misplacement into the jugular vein. After successful puncture, withdraw the needle and advance the catheter. Advancing the catheter slowly at a rate of 0.5 cm per increment is essential for safety. Peel away the sheath, and remove it. Clean the catheter with normal saline. Securement. The external catheter should be gently positioned in an S-shaped loop. Dressing should be applied without tension. Gently press from the center of the catheter outward, shaping along the curve of the catheter. Secure the edges. Pulsatile flushing catheter and positive pressure locking catheter. Layering adhesive tapes in a X pattern to enhance the stability of catheter fixation. Creates a slight lift under the catheter using the tape to prevent direct skin pressure, reduce friction. The edges of the transparent dressing should not overlap. Identifying the location of the tip. The optimal tip position is recommended to be at the middle lower 1/3 of the superior vena cava, close to the junction of the SVC and right atrium. On X-ray, this typically appears between T4, T6 or T7. At this site, the catheter runs parallel to the vessel wall and floats freely with blood flow, reducing complications such as thrombosis and infection. For catheters inserted via the inferior vena cava, IVC, the tip should be at the upper 1/3 of the IVC, ideally at the level of the diaphragm and right atrium. X-ray visualization usually locates it between T8 T10. If the ideal position cannot be achieved, the catheter tip should preferably not be lower than the renal veins. Avoid affecting blood return in renal venous. The neonatal PICC catheter serves as a vital lifeline for delivering medications and providing nutritional support during neonatal treatment. It is a critical medical device in the care and rescue of newborns.